So welcome and thank you for joining us today for the meeting of NYC Health and Hospital Strategic Planning Committee. Today's meeting is officially called to order. So we have Frida listening in a listening capacity only. Frida Wang, welcome. So bylaws, section 14, committee attendance. If any member of a standing or special committee of the board will not be present at a scheduled committee meeting, the member may ask the chair of the board to request that another board member, not a member of that committee, attends the scheduled meeting and be counted as a member for purposes of quorum and voting. Therefore, Fenioski Peña Mora has requested that Erin Kelly, representing Ann Williams Ison, be counted for the purposes of quorum and voting on her behalf. And the request has been approved. Thank you so much, Erin. I would like to propose a motion to adopt the minutes of the Strategic Planning Committee meeting held on January 9th, 2023. Let me ask for your vote individually. Dr. Katz?
Yes.
Sari Hernandez Piñeiro?
Yes.
Erin Kelly?
Yes.
And Jose Pagan, yes. So next we will hear from Mr. Ziegler, Dr. Way, and Deborah Brown as they provide an update on the system dashboard. Floor is yours.
Thanks. Good morning, everyone. Nice to see you. Nice to see those who are remote. I just want to give sort of an overview. Sorry, can you go to the next slide, please? Thanks. An overview of sort of our standard external issues / risks as we think about our strategic processes for the next several months. One, and you'll see budget appears at city, state, and federal level. We were in the midst of the city budget process. Dr. Katz and selected members will be going to testify again next week, I believe, thank you, James, in the next budget hearing. I think, the conversations continue in terms of what our budget looks like, what our relationship to the city looks like. I will not say that there is anything massive or staggering, but it is a necessary kind of part of the dance. I wanted to flag the pricing transparency bill only because there's not always a ton of legislation that comes from the city council that really impacts us directly. This is a bill that would create an office of, I believe, healthcare accountability that, among other things, would look at pricing transparency. It is, quite frankly, less of an issue for us in as much as we take many steps to ensure transparency. Many of you saw we were recently named, amongst the best in the state on pricing transparency, but it is something you may be seeing about in the press and might be hearing about. And I think it also speaks to our ongoing relationship and sort of defining our roles with the city council. On the state side, the budget is now officially done. It is, I believe, the latest budget since 2010, perhaps 2012. It took some time. It is our finance colleagues are doing the analytics on it, so we will not have numbers to share at this point. And I think James and John will speak about that a little bit more in the finance committee hearing coming up. I will say broad strokes, it looks like it is not a negative budget, which is always positive. There were Medicaid increases. There is an EP increase. There is, of course, the carve out on the pharmacy side of 340B that will have an impact. But all told, I think, it seems that we're in a solid place. More details to come on that. I will say that almost all of the policy issues that are not finance driven were stripped out of the budget negotiations. That is in many ways appropriate, though that's not always how it works. It does mean now we have a very truncated legislative session. Session goes through June. Usually, if the budget actually closes in March, that's a lot more time. So we're really talking about 5 weeks now. And so there's a lot of things that we'll be working on. I would say the work has not yet begun in earnest, but it will very soon now that everyone's taking a break from their budget. And a lot of that, I think, relates to some of our workforce and policy issues that we've been talking about. More to come there. On the federal side, same issues, budget negotiations are ongoing. I'm sure you're all seeing in the news that it is not particularly productive in terms of the divisions between the two houses. One way in which that is manifest for us is that the community funded projects, which are known colloquially as earmarks, with which we have done very, very well in the last several years, Unfortunately, the Republican-controlled House has essentially announced that they will not be funding hospital or healthcare-related projects through that earmark process. It is confusing, frankly, how that will work out. We have submitted as a system through the Senate portals. Both Senators Gillibrand and Schumer have been very supportive. We have about 23 to 26 of our projects that appear in their finalized lists. Now the play goes to the House. Again, we submit. Those negotiations are a lot bigger than us, but that's something to watch. End of the PHE is coming up. We've been doing a lot of internal work about what that means, and we are in a good position. And then the other piece that I think we're going to be spending a lot of time on is reauthorization, as you know, as we need to get people re-signed up for Medicaid. So those are the big external issues.
Thank you.
Sure.
Any questions from board members? Thanks.
All right, I'll kick us off with the metrics in our system dashboard. And so on the next page, we're going to start with the positive trends that are beating our goals. And so hemoglobin A1C just keeps going up, up, and up. So 68.7 from 67.4. This is above the target of 67.6. Just a reminder, we hit a nadir at 59.9 in February of 2021. That was pandemic driven. And so now we're above pre-pandemic levels and just continue increasing. And I think this is a lot of credit to Dr. Nicola Davis, our Chief Population Health Officer, her team, Ted Long, the ambulatory team, so the show vans, the pharmacists that we have in our primary care clinics, the apps that are being built to allow patients to track their blood glucose at home. Our ambulatory care experience numbers are also on the way up. 85.7% would recommend this provider's office. That's up from 84.2%. We believe this is including more kind of patient-centered options such as telemedicine. Is improving their satisfaction. In our total wellness encounters, we set a goal at 600, worried that after kind of the waves of the pandemic left, that there would be less reason for people to, or less, encounters happening. But the opposite, we're seeing 1,903 total wellness encounters this quarter, one-on-one debriefs, group debriefs, proactive rounding, or visits to our wellness respite rooms, and that's up from 1,664 the previous quarter. We go to the next page. On our access to care measures, our NYC care continues to go up at 108,672. This is above our goal of 100,000. And that's just the continued hard work. Mr. Jimenez signing people up, our financial counselors in our hospitals doing the screenings and offering it to people who are eligible. Our unique primary care patients served in the last quarter also went up to 416,669. That's above target of 405,000. We'll note that this is excluding all the infection prevention visits, the testing and vaccine visits. So we're comparing apples to apples with the previous quarter now. I'll turn it to Matt.
And then on some of our positively trending financial sustainability measures, on the prior slide as well. The patient care revenue over expenses remains well above the target. We have not adjusted the target yet as we wind down from the public health emergency and manage increases in our risk surplus and our supplemental Medicaid payments, but we'll continue to monitor that and adjust the target as necessary. Good to see our accounts receivable days dipping down through continued work of our revenue cycle teams. And then our large enterprise data center migration project is on track. 79% of the total project is complete, and all of the Q2 milestones were met. So Kim Mendez and team are
on some of our steady trends. Our post-acute all-cause hospitalization rate was 2.2 per 1,000 care days. That's slightly up from 2.1 the previous quarter. The target's 1.6 per 1,000. So we still have some work to do there. But checking in with our post-acute team, they do deep dive on every emission, and all of these in this quarter were deemed unavoidable. They continue to work with their clinical teams, with the hospitals, to try to drive this number back down.
The post-acute division's accounts receivable days are essentially steady, down a little bit. Their focus is increasing on their managed care contracting and collections there. So good to see their focus, and that will be a big push in our FY24 budget. And then the percent of Metro Plus medical spend at health and hospitals is increasing again. 0.7 is still a large amount of money, as you've seen from our risk surplus collection. So good to see that moving in the right direction, and we will be looking at that and hoping to see those trends continue even as the recertification progresses and Metro Plus moves forward with other installations. On the next slide, our our percent of uninsured patients enrolled in health insurance did dip a little bit, still close to the target of 90%, but not there yet. This is from, as you'll recall, October to the end of December of 2022. So it was a busy time on the inpatient and ED side in our system, and we do attribute this to some of those higher volumes as well as just some staff, an unusual number of financial counselors shifting off of their roles and needing to be replaced at that time. So we hope to get that back up in the right place. On my chart, we are looking at this as the testing volumes have declined rapidly. The overall number has dipped. We're proposing to revise the target to 60%, which more accurately we think captures the full mix of emergency room, inpatient, and outpatient volume of signups and what a reasonable target there should be. The number of individuals and the percentage enrolling when they are attributed to our primary care providers remains at 75%, which is fantastic. But I think stabilizing us all at 60 and then building up from there again would be an excellent goal.
The 60% is also Epic's honor roll benchmark. So if you hit 60%, you're on their honor roll.
And then on e-consults, that number dipped a little bit as well. I do think this is about the intense volumes we were seeing at the time and some of our specialty providers not able to see as many patients and review these consults in a timely fashion.
We're looking at some of our negative trends for this quarter. The follow-up appointment kept within 30 days after behavioral health discharge dropped from 53.4% to 48%. The target's 50%. Speaking to our OBH team, there are over a third of our sites that are above 60%. So there are kind of high achievers in this group. But we think this one-time decrease is due to multiple sites not completing fully into Epic the information. And once that backlog is rectified, we expect this number to go up and be closer to where we were. The percent left without being seen in the emergency department crept up from 4.2% to 5%. The target is 4%. This is purely driven by the record volume that we're seeing in our emergency departments across the board that's driving our record inpatient volumes. And so knowing that this is our new normal, more EDs are moving providers to the front end and triage. Provider and triage can quickly discharge folks, route them to a more appropriate care, such as express care. And we're imminently going to pilot virtual express care in the Kings County Emergency Department with kiosks, so that instead of waiting with a low acuity complaint, you can be connected to a virtual provider and have that taken care of quickly. And then finally, our inpatient care experience overall rating dropped a little bit from 6.17% to 60.2%. This is also volume driven. So if you're getting admitted and waiting in the emergency department for a long time for a bed upstairs, it kind of sours your entire experience. And so as we improve kind of patient flow through our entire system here, it's going to help improve this number.
Let's ask a question on the metrics. Two questions. One, the MyChart activations. I know that a number of hospitals have been doing performance improvement projects around how quickly doctors are able to get back to patients. I think once we have enough of them, it would be useful to look to see how they've done and what systems worked best, because the activation and the continued activation, I think, turns on their ability to ultimately get through to a provider. And the second question is just the kiosk at King's. Fascinating concept. It'll be interesting to see if being in a hospital setting and being able to connect to a provider is a different kind of experience. You know, it'll make people more likely to do a virtual visit. So I look forward to hearing more about that.
That's the goal, so that the next time they don't even need to come in, they have a low acuity complaint, they can just connect from home. We are already doing it as almost like a pop-up valve for our ambulatory clinics, starting with pediatrics at Coney Island. And so with the surge of RSV in the winter, you quickly fill your walk-in slots, and then you have to send people away, and that's unfortunate. They're coming to seek care, their child doesn't feel well. And so we set up kiosks so that they can pop onto virtual express care and see a provider, maintain that access.
There's a positive change in our system at Gouverneur. A patient of mine had sent in a question. A pool reviews them. So before the doctor gets them, someone's reviewed them.
Right.
And the nurse said, well, we don't have any drop-ins today. Go to, and they mentioned the commercial urgent care.
Mm-hmm.
And so I spoke with the leadership and said, no, you send them to our emergency care virtual. And I just reviewed a message over the weekend where they were said, if this is urgent, then please contact our virtual emergency room.
Yeah.
So starting to act more like a system that recognizes what its assets are.
Yeah. And Sally, your comment about MyChart is right on. The MyChart steering committee just met last week in discussing moving from activation kind of metrics to utilization metrics. And so we think we should continue trying to sign folks up for MyChart, but it doesn't help if they just sign up and never log in and utilize the tools. And so we looked at all the utilization metrics that Epic already has for us, kind of out of the box. And we're in the discussion of at what point should we switch this on this dashboard from activation to utilization.
Thank you. Thank you, Eric.
I think that would be a great conversation to have.
Yeah.
Is it a place where you go check how much you owe H&H, or a place where you make an appointment, or a place where you learn about your health, or so many angles to it. So is that what they're going to talk about?
So the ones that they have currently are like inbox kind of message response time. So like what percentage are responded within 48 hours. They also have ones that people who do log in, at least once in the 12-month period, 12 months from this moment back, how many times did they log in? And our numbers are somewhere like close to 7 times, right? So those are people who are engaged. But there wasn't one perfect one. I want to know is of all the people that we've signed up in the past 12 months, what's like the average number of times that they log in? So not just the ones that keep logging in. And so the follow-up was to go back to Epic and say, right, we don't love any of these as one utilization metric. I guess all of them added together, pretty good. And so we're going to work with them to see if we can get one that we feel like will be worthy to put on here.
That's great.
It's a good project.
Just one other thought is it's so helpful clinically to be able to tell people, and you'll see the labs results as soon as I do. And it just makes a huge difference because that people worry about their labs. And then as a provider, you have to figure out, well, so am I going to have them come back again to get the labs? Am I going to call them? If I call them, will they be home? When will I mean, there's like transmitting labs. If you're a primary, it's like a huge issue that's pretty much solved when they have this. Now my standard thing is you'll see them same time I do. Of course, if there's anything, that's really wrong, I'll get in touch with you. If you have any questions, you can contact me. So much easier than trying to keep lists of who to call, especially because even you as a provider, they don't all come the next day. Depending on what you order, you might get some the next day, some in 3 days, some in 5 days, right? And so just to be able to say, look them up yourself and get in touch if there's any question. And of course, if there's a panic value or, that's different if it requires action. But it's a huge improvement in the delivery of primary care.
Yeah, I mean, there's so many reasons. Like, I always go in every time my kids are sick because I can't remember how much they weigh to dose medications. And so I go into the growth charts and look at the last time, 45 pounds, right? Tylenol this much, ibuprofen this much. But there's so much information in there. All right, so let's move on to our racial and social equity measures. So we wanted to provide a little bit more information this time. So this table is new. Percent of new physicians hired being from underrepresented minority groups. And you'll see the numbers are moving up across Asian, African American, and Hispanic. But we think probably due to us getting better with our quality improvement around collection of our real SOGI data. So you see the unknowns went from 60.8 to 48.7 to 23.1. So it's hard to say, right, that this is not just the same proportion, but more known now. But the good news is that we're going to get closer to a real baseline once we see this unknown get down to a smaller number, and then we can see real trends from there. Any questions on this one? And then I'm going to actually let Hillary speak to our number of equity lens applied to PI projects.
Sure. So this is a measure, I think we've now had it for 3 quarters in this meeting. And we're looking at the number of equity lenses that are applied to each of our improvement projects. It does lag a little bit. So when you look at the October through December 2022 data, there were 16 improvement projects with equity lenses applied. And then going back to July through September, there were 42, which is slightly above our target. We really aim to have 40 per quarter. And what we mean by that, just to make sure everyone is on the same page, is that we look at the data for each of the improvement projects for the primary aim measure, having to do with either primary language spoken in the household, race, ethnicity, age, and then seeing, was there a disparity identified? And then what we're doing is working with each of the sites to encourage them to apply other Plan, Do, Study, Act or PDSA cycles to reduce that disparity. Any questions about that measure?
I had a general comment connected to this and the previous measures, which is, it's nice to see that A1C is improving and how we manage it, and that the QAPI meetings and all of that, you can see the improvement that is reflected in this slide here. But do we know, for example, I mean, we know, for example, that the A1C that it went up because people are going to their primary care visits. That's the explanation in the slide. I feel like we need to figure out a way of knowing precisely how that measure was obtained. Maybe you have an answer to it, but linking these things together. So, for example, are we hitting the measure because a facility is doing better than another one? Are we leaving some groups behind when we hit that measure? Almost like a percentage attributed to each element. And you may have that already, but it's something that it may be worth sort of like thinking through so that we know who is it that is going to primary care visits and improving their A1C. Is it MetroPlus doing it? Is it another health plan? Is it us? Is it the ACO? It's very hard for me to like gauge what's driving that target.
Yeah, I mean, in the past, we've done deep dives on some of these metrics, and we're happy to come back next time with a deeper dive on A1C and invite Dr. Davis to come join us. What we do have, which is really cool, is our population health dashboards now can be filtered by socio-demographics. So we can look at primary language spoken at home, real SOGI data, insurance status, those types of things, and see if there's any disparities, right? And so for A1C, the last time I looked, there was not. There was one on depression screening where primary Mandarin speakers were about 20% below. That one jumped out the first time we created this, and we've since closed that gap. But talking about, right, all the different ways that you could analyze by payer group, I don't think we necessarily do that. We do look at how facilities are doing, right? How's Jacobi doing compared to other hospitals? How are each of the Gotham clinics doing? So we could tell if, right, who our high performers are and who our laggards are that way. But if interested, any of these metrics we can do a deep dive on and bring it back here.
Yeah, I think if you pick one metric that is the most, one of the most relevant. I mean, A1C is in the dashboard, so that may be a good one.
Yeah.
But
so another example of the A1C is our show bands. Ted often uses this fact or statistic that our homeless patients now have higher A1C control than our general population of patients. And so taking a vulnerable population like that and getting that up certainly brings the average up as well. But yeah, we'll do that for next time.
Yeah, thanks.
And then maybe for the last time, our COVID-19 metrics here, no real significant changes here. The percent of COVID-19 occupied beds went up by 2%. Oral therapeutics down by about 1,000. Infusion treatments down by almost 600 here. But we will continue to treat COVID just like we treat every other illness and condition that comes to our emergency departments. But with the public health emergency ending on the 11th, I think we would all, like a turning of the page or end of an era if we can retire this slide.
And I was going to add that the comment that I made, because I've seen it when I've done the Joint Commission visits and all that, I know the level of detail and the data that you have, and it's just thinking about like board members having that opportunity to see how much goes on, that beyond just the metrics that we discuss here, So that's what I was coming from. It's always very impressive how you're able to slice the data and the example that you provided. It's a good one with Ted.
Great. Okay, well, a couple other slides on here. Just the overall snapshot of the dashboard. I always tend to say on this, red is our friend, right? Tells us where to focus, and if we were all green, our goals would not be high enough. But overall, for this snapshot in the fall and early winter of a very, very busy period, a lot to be proud of and a lot to work on, as always, in our system. And then the final slide to go into, we wanted to discuss with the board some 5-year system strategic goals. Starting off of the work of this committee, the work of other committees, the goals and priorities in our community health needs assessment, and our overall system strategic pyramid, we have 10 5-year system goals that we really hope can be, help us and the board and our teams all around the system orient ourselves on a longer view of what we hope to achieve in this medium to long term. And so just walking through them, not in a strict priority order, but all very important ones. The first that we've really talked about together is making health and hospitals a friendlier place to get care. We monitor our patient satisfaction measures. We look at all that carefully, but those are lagging indicators. And I think we all walk into our facilities, and the way we treat each other and the way we want our patients and everyone else to be treated is always, front of mind and a continued part of the culture change that we're all working on together. Related to that would be the second one on here, which is the patient satisfaction scores that our plan and our system get together when we work together. Working together as a plan and a provider have always been a key goal, and then being the best plan for low-income New Yorkers on Medicaid is a great goal for us over the next few years. Connected to that satisfaction and being a great and friendly place to get care is the percentage of our staff who are in permanent positions rather than in temporary or floating positions. So getting our nursing staff, for instance, back to pre-COVID levels of being in permanent positions rather than temporary is a great goal for us. Having a physician workforce that looks more like the patients we serve and continuing to be a leader in that area is another goal for us over the next 5 years. We were talking about diabetes control, hypertension as well, these key chronic disease measures for patients experiencing homelessness, who are a big part of who we serve and a critical issue for the city writ large, will be a goal of ours. Housing as many of those patients as possible. 3,000 would be the goal of the next 5 years. It is an exciting and important goal for us over the next 5 years. Our work on lifestyle medicine, growing the number of encounters, growing the number of clinical teams we have working on this will be a big goal. Underlying all of that is our infrastructure and the equipment that we have that make us resilient, secure, and sustainable. In the prior committee meeting, the Capital Committee, you saw how busy they all are, and we have a list of key major priority projects and core infrastructure that we want to make sure we deliver on in the next 5 years. Along with that would be our carbon reduction goal. We signed a pledge to reduce by 35% by 2030. We think we can hit that in 5 years rather than 7. And then finally, a big core part of our infrastructure, staff satisfier, financial implications, this organization of our operations is our payroll and scheduling system. The next year will be critical to getting that rolled out, and then implementing it and being a good user of it will be critical over the next 5 years. So these are 10 that we've worked on as a team, building off of the work we've done together, and that our community and others suggested to us in the community health needs assessment. And so we're very excited about these 10 goals and look forward to working with the board and welcome any and all feedback on.
Thank you. Are you thinking about ways of integrating these goals into, I guess, the dashboard, or some plan that says, okay, how are we doing over the next 5 years in terms of housing 3,000 patients, or is it within that dashboard or some separate?
I think we'd welcome feedback on it. We certainly thought about it as a little bit separate, just because it is a slightly longer timeline, right? The dashboard now is definitely quarterly. It has annual lookbacks, but I think tracking, there are KPI, key performance indicators, and goals associated with all of these that are more detailed. And so, whether it's at every strategic planning committee, whether it's at separate venues for the full board, certainly updating on this on a regular enough cadence that we can see progress would be great, and we would welcome the board's feedback and suggestions on how to structure that.
Right. I mean, I think the idea of a dashboard is really where are you now?
Yeah.
Right. And how does the board know we're doing a good job? But I wanted to also have, okay, 5 years from now, what could we celebrate? And so we tried to choose things that had a longer, horizon that we would be able to celebrate having achieved. But I think definitely the idea was always to watch it, but not to suggest, that we can quarterly necessarily show progress on these. That these were designed, just to, the payroll and scheduling will have a set of markers, right? Because like any IT project, it has to roll out. But at the end of the day, it either works or it doesn't. Right. You could meet all the markers, but if at the end of the day, the system doesn't meet our needs, it will be a failure. Right. So that's what we were trying to aim for, things that we could feel in 5 years. Look, we can celebrate this. Right. We were able to do it. It also tries to follow, the idea that the first 5 years, that I've been here, there were certain what I would call stabilization things that were necessary, right? The elimination of the huge deficit, the having a functional Epic system, working as a system, right? That you couldn't begin really to look at these things unless you could at least fix your bread and butter issues. But having fixed our bread and butter issues, now we should think as an organization, okay, well, so, what could we get? And none of this is new. I mean, that's why I think they did a creative job in showing it's all in the things we've done before, but it's meant to be in a format, and it will be even more so as we go, that people can celebrate. We did it. I think that really helps an organization to feel good, because the work of health and hospital is never going to be done. And quality of care is not a yes/no question, right? You'll have people who got amazing care. You'll always have some people where something went wrong. I mean, it's not, I wanted things that you could say, wow, we housed 3,000 patients. Isn't that amazing? Right. So nothing new. I mean, you see the improved diabetes control. I mean, we're just talking about that. I mean, that's a perfectly good one, to track quarterly, but also I'd like, some, parameter that, in 5 years, this is where we're going to be on them.
Excellent. Sally, any?
I just had a quick question. Maybe I may not have focused on this. Can we say that on the metrics across the board, we're doing better than we did pre-COVID? If we looked at, say, the quarter just before COVID started, can we say that?
I don't know that I could say that unilaterally, right? I think we had certain ones where we may not be, but let me just look at
It's certainly worse on staffing, and something I care very much about, right? Much higher use of registry than pre-COVID, right? Because of, the ways that our salaries lag the other safety net systems and the job market in general. So that's one where not anybody's fault.
Affected by COVID because it opened opportunities that nurses may not have.
It opened opportunities, and it caused a lot of people who were towards the end of their career to say, I'm done. And a few people early in the career to say, this is too much. I mean, I think there's still a fair amount of post-traumatic feelings about, a lot of moral questions that people faced about what it was like to care for people when you didn't have enough resources to care for them, and feelings of guilt or worry, I wish I could have done more for that patient. So I think it causes some people to leave the profession to feel that it's too difficult.
And of course, that's a lot larger than H&H, even. with the
Absolutely.
distinctions between us that Mitch identifies.
Oh, absolutely. All the systems are having trouble recruiting enough nurses.
Just curious about those indicators that weren't directly, when you created the new outcome because of COVID, if we were just going back in time,
Yeah. Yeah, I mean, we can certainly give you the breakdown just from memory, right? The ones that are better, that are just striking, the number of unique primary care patients is higher, right? So an indicator that our system grew and stood up and, more people are eager to come to us for regular care after COVID than they were before, right?
Yeah.
That the chronic disease measures we've been talking about are better or at least stable is a remarkable achievement given what the city has been through, right? At one of the most calamitous health events in history, and our patients are back where they were on diabetes control and things like that. But we can give you the breakdown from,
Okay, thank you.
Q1 2020 versus this. It's a good question. Thank you.
So just one quick comment on it. I know that, when did you join? 2018? 2018.
So I celebrated 5 years with the close of the year.
No.
So now this is my 6th year.
Ooh.
And I joined in January 2019, and you joined at the same time, January 2019. So when I see we went through a pandemic, well, the WHO said it's over, right? And then I see this and I see how much you should be very proud of the work you've done connecting our strategy, community needs assessments, how we track information. And then one advice that somebody gave me when I started here 5 years ago was have some goals that are important and stick with them and work on them. And I like the fact that we have identified things that are important to everyone, to all of us, to the board, to staff, and so it's exciting to see that we're thinking of being around 5 more years.
Oh,
working on this. So on that note, any other questions or comments? Okay, and Frida Wan also said that she likes the plan, and by the way,
Wonderful.
congratulations on that. So on that note, is there any old or new business to come before this committee? Hearing none, then the meeting is adjourned. Thank you so much.